Thanks very much for coming to this session on assisted dying and whether the time has come to legalise it. Hopefully most of you know me, but my name is Paul Weatherly, so I'm going to just chair this session. I'm really delighted that we're able to put this session on as part of the festival, because assisted dying is something, and the question of whether it should be legalised has become a much debated political and social issue. It's not something that's going to determine the outcome of the next general election, I don't think, but clearly it's something that's moved up the political agenda. It's an absolutely critical issue for the people who are affected by those issues, obviously. It also raises quite fundamental questions to do with the kind of values of our society, questions about ethics and rights. And it also, of course, raises issues about our political process and how our politics deals with these kinds of questions. So I'm really delighted to have three excellent speakers to come and talk about this with us. Just before I introduce them, I just want to, a couple of housekeeping things. One is to just ask that you all switch off your mobile phones. If you could do that, that'd be great. And the other one is to point out that we do have a film crew in the room. So all the speakers have said that they're okay with that, which is very kind of them. And so I'll just let you know that, really. If you're not happy with that, there's not much I can do. So hopefully you will be happy with that. So we've got three excellent speakers. Each one is going to talk for 15 to 20 minutes. So we should have time at the end for questions and discussion. First of all, we've got Sharon Young from Kingston University, who is researching issues around assisted dying, and we'll talk about her research, in particular in reference to kind of the discourse of rights around it. Then we're very glad to welcome Greg Judge from, I must make sure I get this right, from Disabled Activists for Dignity in Dying, who's going to talk about the issue from the particular perspective of that group and its position on the issue. And then I'm also very pleased to welcome our own Professor Michelle Briggs, who is the Professor of Nursing and co-director of the university's pain research team, who's going to look at this issue really more from a medical practitioner's point of view. Okay, so we're going to take those three talks consecutively and then open it up to questions and discussion at the end. So I hope you're all going to have a really enjoyable and interesting session, and I hope you'll join me in welcoming our three speakers.
Hello everybody, my name is Sharon Young. I'm a final year PhD student at Kingston in the Department of Politics and Human Rights. My thesis is looking at assisted dying from a human rights perspective. But I haven't always been an academic. In fact, I don't really consider myself an academic. I qualified in 1992 as a physiotherapist. And my first job was working with young men who were dying of AIDS at a busy London hospital. And I think that was a real shock for me, because in the early 1990s, the way men dying of AIDS, it was horrific. They were emaciated, they had persistent chest infections, and many of them had open sores covering their bodies. It was a really horrific way to die. And then throughout my career, I was often struck how, often two patients with a very similar diagnosis and very similar symptoms perceived and reacted very differently to their illness and dying. So really my thesis is a bit of a combination of my practitioner experience and an academic approach. So when we look at this question, is it time to legalise assisted dying, there are a series of sub-questions when I look at it from a rights perspective. Okay, so I want to know, why do we talk about a right to die? Is there a right to die? And part of my literature review has been looking at modern attitudes towards death from a historical, social, political context. And then you need to look further at what are the conceptual elements of a right to die, and whether a normative framework of human rights supports this. What does it mean to have a right to something? And of course, when you look at that, you need to examine whether the current legal position, what is that in the UK? Is there any need for change? And then I'm particularly interested in words. I want to know why we talk about a right to something. So when we talk about a right to die? Who is it that's promoting this discourse? How is it being used? And does it really articulate what's important to people at the end of their lives? So who's promoting the idea of a right to die? Well, the media are. Don't know, on the television there'll have been a lot of coverage of particular individual cases, and national newspapers also cover cases. You might have heard of Tony Nicklinson, Paul Lamb, Debbie Purdy as well a few years ago. And then there are campaigning organisations such as the one Greg's going to talk to you about in a little while. And then healthcare policy, actually, our own NHS. If we look at our 2009 NHS constitution, we talk about patients as having rights. Patients have rights to be treated with dignity and respect. They have a right to free NHS treatment, and healthcare professionals have a duty towards their patients. They have a duty not to discriminate, and they have duties to provide a good standard of care. So why do we need to look at this question now? Well, despite all the advances in medical technology, 100% of people still die. I hope that doesn't come as a surprise to anybody, because you will all die. But really, our modern dying trajectory is very different. 50 years ago, people became ill and they died at home. They were looked after by their family, they died in their own beds. It would have been very common for children to have witnessed a dead body, even touched a dead body. Many scholars argue now that the subject of death is taboo, and others would say death is sanitised. Nowadays, people don't die at home, they die in a hospital environment or a hospice. We have healthcare workers, doctors and nurses, to perform all the roles in looking after the patient. We don't often see a dead body. Although the contrast to this is if you look at the BBC News, who are very good at covering crises, emergencies, wars, and we look at the horror films we can see in the cinema. I don't know if you've played Call of Duty or other video games. You know, you can actually set the level of gore when you're playing these video games. I think one of the reasons people look towards assisted dying as a possibility is perhaps that we're less community-oriented now. Years ago, people would meet in their community centres, their village halls, their churches, and nowadays, in my opinion, I think young people tend to go to work, they come home, they access their mobile devices. You can gain an awful lot of information, and yet you're there on your own to make and negotiate your own lifestyle choices and think about moral dilemmas in the privacy of your own home. Nowadays we have a very different role with healthcare professionals. Many years ago, the doctor would come on his ward rounds, he'd stand at the end of your bed, he'd tell you what was wrong with you and what he was going to do about it. We don't have that now. I don't know, maybe you're the same, but if there's anything wrong with me, I've Googled my symptoms before I go to the GP, and I have an expectation that he's going to be prescribing something that I've read about online. So we have a much more consumer relationship, and I think Michelle is going to talk a little bit more about that later. So in the first stage of my research, I looked at the different debates on assisted dying in the House of Lords. It was debated for the first time in 1936 as a voluntary euthanasia bill. And at that time, the argument rested between merciful, compassionate release of a person who is suffering incurably. In 1936, there's no mention of rights, autonomy, patient choice. It was purely a medical professional mercifully helping somebody who is incurable to die. By 2003 and 2006, the ethos changes dramatically. There's a focus on personal autonomy and choice, the idea that an individual who is mentally competent and terminally ill should be able to ask for assistance to die. And I think this sums it up really. Lord Haskell says, we're here to serve the public as a whole. We legislate to preserve people's rights and freedoms. So by 2006, the emphasis is on choice. In 2013, the bill was debated in the House of Lords in July this year for 9 hours and 43 minutes. And I have to say, I didn't sit through all of it. It was really interesting, though. There was really a sense of respect and solemnity. All of the people who spoke used their full 4 minutes, and they all had a lot of convincing arguments, both in opposition and in favour of legalising assisted dying. I wonder if it was taken so seriously because there was a huge amount of letters written to peers in the House of Lords. So there was an overwhelming public response, which we might talk about a bit later. And also the Supreme Court had recommended that Parliament address the issue of assisted dying. So the debate now, today, I think, is summed up by Baroness Kennedy. She says, we're dealing with the right to individual autonomy and bodily integrity, and with the right to make decisions about our own lives. So it's a profound issue of human rights. On the other hand, there's a need to preserve the wider fabric of an ethical society with an overriding principle that human life is to be valued and guarded against violation and abuse. Okay, so if there were a right to die, what are the legal mechanisms that could support a right to die? Well, I'm sure many of you know, in 1948 we signed the Universal Declaration of Human Rights, protecting the fundamental freedoms, respecting individual dignity and worth. The 1950 European Convention on Human Rights set out these freedoms, and 1998 the UK adopted the Human Rights Act. So Article 2 of the European Convention talks about the right to life. The right to life is an absolute right. Even in an emergency, we all have the right to life. Some scholars have argued that a right to life might involve a reciprocal right to die. When you look at the right to life, I think you have to look at the boundaries of that right. So do we have a right to life only if we have a good quality of life? What about if we're suffering terribly, we have no life quality, our life is not worth living? Can we then relinquish that right to life? Some people that have gone to the High Court and requested assistance to die have cited violation of Article 3 of the European Convention. They said that not being allowed to end their life amounted to torture or inhuman degrading treatment. Now, it sounds a bit far-fetched, perhaps, and my supervisor raised his eyebrows as well when I mentioned this. But if you think about doctors as being agents of the state, and somebody who is severely ill, perhaps suffering motor neurone disease and can't move, or a tetraplegic who's paralysed, and they're desperate to die, if they can't end their own life by legal means, is it degrading and inhuman not to allow them to end their life? Some people have quoted Article 8 and said we've got a right to privacy. You know, our lives are our own, they're private, we can do what we like in our own house. But in a democratic society, you have to balance the privacy rights of an individual against the welfare of wider society. And Article 14 talks about discrimination. So if you are one of those people that I mentioned, you're unable to take your own life because you're physically disabled. What about then? What happens then? Your only option, if you don't have help to die and you're desperate to die, is to starve yourself. So if there was a right to die, let's say, there are some potential issues, and Michelle's going to cover these in depth a bit later. When you have a right to something, if you have a positive right to something, it often necessitates somebody to help you fulfil that right, a duty bearer. And the proposals so far have looked at medical professionals, doctors, being the people who would help you fulfil that right. But Michelle will cover that in a bit. For me, one of the greatest problems I see is that a right to die is culturally relative. People who want assistance to die tend to be white, middle class, upper class, educated, and often secular. Hindu, Sikh, Muslim groups tend to be opposed. And then for me, there's the question about whether a discourse of rights, when we talk about rights, whether we accept that the idea of a right to something evolves and reflects the society in which we live, or whether by allowing that to do so influences normative values. So there seems to be more prominent focus on rights. We have a right to this, a right to that. Is that okay? Or is that going to affect the fabric of our society? So as my research, I needed to look at who's defining the terms of the debate. So I've looked at campaigning voices, and I've done a case study of the organisation which Greg's part of, Dignity in Dying. I'm just going to make a couple of points on that, because he'll talk about that later. But I thought a definition of campaigning was really important here. Campaigning is organised actions around a specific issue to bring change in the policy and behaviours of institutions or specific public groups by mobilising others. So Dignity in Dying are an incredibly innovative, powerful, thank you, Lily. They're innovative, powerful, and they're dynamic, okay? They're a really good campaigning organisation. They have organised actions, they're striving to bring about policy change, and they're very good at mobilising the public. So by framing assisted dying as freedom of choice, focusing on human dignity and an expression of control. And their vision for the organisation talks about choice over where we should die, access to information about end of life, and control. And for me, because I'm interested in discourse, it's a really powerful discursive strategy. When you talk about choice and access, which are already present in our healthcare policy, and then you add on to the end control over when we die, by linking those ideas together, it sort of suggests it's a common sense. They should be together. When we have choice, we have access, we ought to really have control. And Dignity in Dying use specific tactics. I think their most persuasive campaigning tactic is that they've got a collection of personal stories on their website written by people who are dying or by families of those who have died. And these personal narratives really encourage proximity to the debate by giving some real life experiences. So for example, just one I picked out, the option of assisted dying would give me such comfort to know that I didn't have to go on suffering forever or have to take measures to end my life in another way. So aware that these personal stories reflect the ideology of the campaigning organisation, I wanted to look at other voices. I wanted to look at public voices. So I've been doing focus groups, small group discussions with participants who attend a death cafe that I facilitate in Hampstead, where people come together to talk about death and dying. We don't kill them off at the cafe, just in case you're wondering. And I wanted to talk to them about their opinions on dignity, suffering, choice, and rights at the end of their life. And I'm going to let their quotes speak for themselves. So one person said, "The thing that makes me angry is the disrespect for people who want to die. You're not allowed to say, 'I've had enough of this.' Everyone should be able to decide for themselves. I think that when people are old, they can be swayed. So there's the worry of undue influence. But I'm totally in favour of assisted dying. No one wants to die. What they want is an end to the conditions they are experiencing in that moment that is causing them to suffer physically or emotionally." I thought that quote was really insightful, and as a physiotherapist, that really resounded with me. We then went on to have a long discussion about whether anybody does want to die or they just want an end to the conditions they're suffering. And then finally, one lady, she was a severely handicapped lady, and as she left, she just threw out this comment, which was fantastic. "For all this publicity and everything going on about the bill, they're just clueless. And what we're doing here is getting to the bottom of what it's all about. So for me, that really authenticated my research. So in conclusion to our opening question, is it time to legalise assisted dying? If not now, then I think soon. Because I think any government that ignores the will of its citizens does so at its peril. And the reasons I think that it will happen is because of public pressure. Also because the nature of modern society. I think recommendations from the Supreme Court have an impact, as do campaigning strategies of powerful organisations. Thank you for listening.
Okay, and now we'll move straight on to Greg. Thanks very much.
I think in terms of the question whether we should legalise assisted dying in public policy, here and now in the United Kingdom, I think first of all we have to realise that public policy and the decision makers that make up the scrutiny of proposals such as this, they have many issues they have to contend with, both within a public healthcare realm of policy and in all the other public policy decisions they have to make in general. But assisted dying is different to many other policies that go across the desks of politicians, because it's a hidden problem. You have a range of other healthcare issues, such as an ageing population, the pressures of cancer drug funds, and the need for an expanding budget of the NHS. These are all things that people see day in, day out. The pressures of an A&E and at GP surgeries. But assisted dying, or the need for an assisted death by terminally ill people, is a hidden problem, because we don't like to talk about death. Death is a taboo, and people try and hide away from that, understandably. It's a difficult subject. Recent research by the organisation that I represent, Dignity in Dying, recently found that 7% of suicides in England, the people of that 7% have a terminal illness. And every fortnight, someone from the UK travels to Switzerland to die. But I hasten to add that those that travel to Switzerland, they only do so because they have the ability, the health to fly to Switzerland, which not all terminally ill people have. They have the money and the means to actually get there, which in essence is another barrier to people accessing clinics like Legalise in Zurich. And ultimately, 10 times as many people, dying people, are in their lives at home than the small percentage that actually go to Switzerland. So, some opponents, you may hear them say that we don't need an assisted dying law in the UK because there are opportunities and facilities available in countries outside, abroad. But that may be well, but research is showing that a very small percentage of people are actually using those facilities, when in fact the problem for people at home who they just can't travel for whatever the reason, that we still have an issue and a responsibility to hear their views and represent them. Now, Sharon very kindly sort of caused me a hiccup here, so I'm going to tell you a story, which is one of my campaigning techniques. And I think, it's all well and good talking about, statistics and figures and trying to quantify, the issue. But ultimately, thank Sharon, one of our key aims of the campaign is to really put a human face to the issue, because these are human stories, that have brought us to this point where we're campaigning publicly for a change in the law. One of our case studies, that we come in touch with is a woman called Heather Patton. Now, Heather isn't terminally ill herself, but her son was. He had Huntington's disease, which is a hereditary degenerative neurological disorder, and it gets progressively worse, and there is a terminal stage at the end. Unfortunately, on his 42nd birthday, he told her that the best present she could give him was enabling him to die, which was, I think when I spoke to her last, she said it wasn't an unexpected shock for her to hear that from him, because they knew, what the end point is with the disease. But essentially, what transpired is that she refused because she didn't accept that was the right thing for her to take part in. And he went off just out of the blue, missing eventually for 6 weeks. And he called his mum 6 weeks later, and he was in a small cabin in Scotland, and they live in southern England, so quite a distance. And he tried to starve himself to death, which opponents say is another reason why we don't need a change in the law, because people can starve themselves to death. That's another exit they can use. But it hadn't worked, and it was taking too long, the starvation process. And so she travelled up to Scotland and found him in a complete state, and essentially she helped him to die, and was put on bail for murder in the following weeks. And eventually, a year later, she was given a conditional discharge, so she isn't facing any criminal prosecutions now. And I think that's a key part of why we're actually campaigning for a change in the law, because under the current law, the Suicide Act, 1961, I believe, the punishment, the custodial charge can be a maximum of 14 years in prison. And under the assisted dying bill, which is being proposed currently by Lord Faulkner in the House of Lords, I think one of the key changes, which I've noticed from reading the policy, is that at the minute, just like with Heather's situation, the event happens, the assisted death happens, at like point A, and then all the investigation takes place after that point, and that's the point when your star witness, the person who has a terminal illness, for example, has died. You no longer have them there to give you a series of events and to help police and judicial authorities investigate the issue. Whereas under the assisted dying bill, one of the key safeguards is that the investigation process and the checks and balances is taking place before the death. And so that star witness, if you want to look at it in a criminal concept, that star witness is alive, maybe not well, but they're there to tell their story and to give testimony as to why they want to die. Now, one thing I want to clear up, because I know obviously I'm here to talk about disabled people and our relation to the bill and to the concept of assisted dying. But I know Sharon mentioned Tony Nicholson, who I know some of you may have read up on this area of policy. Is a really prominent person. A few years ago, with the support of his family, he campaigned for assisted suicide. Now, assisted suicide, let's put it this way, I suppose. In the area of euthanasia and assistance to die, or the right to die well, there are roughly 4 key areas, or 4 key types of suicide, if you want to put it in those terms. And they can be split up on 2 principles: whether the dying person or the person who wants to die is doing so voluntary or involuntary, and whether they are going to self-administer or commit suicide by themselves, or they're going to have the last action of death done against them or for them. Now, in terms of Tony Nicholson, he was, and equally so, Paul Lamb, who is a paraplegic or tetraplegic, and who's currently fighting on behalf of Tony's case since Tony died of pneumonia several months ago now. They campaigned for assisted suicide, which is going to include disabled people as well, who are not dying from a terminal illness. Now, disabled activists for Dignity in Dying, who should group I coordinate, we don't agree with that. We have actually quite strong reservations about assisted suicide, because I think ultimately, if you're going to make a law that has the proper safeguards and the proper social conscience and responsibility, it needs to be based upon natural lines. Identifying points that both people within the policy realm and also public support can understand that if you're terminally ill and you're dying, being assisted to die isn't killing you. You're merely enabling someone to take control of that dying process, which the only fault of that happening is sadly the terminal illness. Whereas if you have a disability and you want to die, you're interfering with your life path, with general, quality community care and support packages. There would be no reason why you would die at that point. You'd still carry on living, and so you're trying to interfere, with a living process, not a dying one. So yes, we campaign for assisted dying, and not for the other types of the right to die, and that's an important point to make. With Lord Falconer's assisted dying bill, which is the current proposals that are on the table, they actually have been going through the House of Lords over the past year, and it was only last week we had the first day of our committee stage, which is where the House of Lords go through the detail one by one, scrutinising it to make sure it stands up to the view of the public ultimately. Now with the safeguards, which I think have to be the key part of the bill, to ensure that vulnerable people in the community are protected ultimately. You have to be terminally ill with less than 6 months or less to live, and that prognosis is to be decided by not just 2 independent doctors within the clinical setting, but we've actually just accepted a point that's been long proposed by the opposition within the debate, which is that there should be a judicial mechanism within the bill as well. And so Lord Panic put forward an amendment in the committee stage just a few weeks ago, saying that there should be an aspect of the family law division of the High Court which should be involved in determining whether someone is terminally ill, whether they're mentally competent, and whether they've made a clear and settled decision to end their own life. And so that's a really big step forward, because not only are we listening to the opposition and to people's genuine concerns, we're acting in a respectful and collegiate way to ensure that the bill has the confidence of absolutely as many people as it possibly can, because ultimately, if it's to become public policy, in some small way, we all have to respect it and take ownership of it, and so it needs to have the confidence of as many people as possible. One of the key area or safeguard I think is really important is that the patient has to have an independent witness in the process. And I know a lot of people talk about undue influence and coercion, and I think actually having an independent witness who is not a relative, not a friend, or not part of your current clinical team, that's a really important aspect, to actually have someone witnessing the whole process, and to know that it is a reasonable process with the patients involved, at the centre of things. One thing I would mention is that a key point of the opposition is that Belgium and the Benelux countries, they have passed right to die legislation in the past, and there's a fear that we'll have this bill and then we'll go further and have the other types of right to die as well. But ultimately, countries like Belgium, they have set their policy out on a much wider spectrum from the very start, whereas the UK is following in the footsteps of US states of Oregon and Washington, who Oregon, they passed their law in 1997, so it's been going for 17 years now, and there's not been a legislative or public demand to extend it throughout the life of that term. I will end on the issue of disabled people and our support. Dignity in Dying has done a range of polls with independent pollsters on a lot of different subgroups and issues around the bill. And what we have found is that the disabled people, over 1,800, which were polled, that 79% supported a change in the law. And I know when you talk to groups like Not Dead Yet, they will say they are an opposition disabled group, and they will say the majority agree with us, and so understandably with polls you have other polls saying the opposite thing, and it's a bit of tit for tat. But I think ultimately what it shows is that disabled people are just like any other group. There is a spectrum of opinion. There are people with a range of views, and so it really opens up that debate. And so what I would say is that at the minute, when you talk to the disabled community, there is a tendency to talk about death in the negative, in terms of a victim type discourse, with people talking about killing and murder and having death done to you against your will. Where I'll just end on Sharon's point, talking about that 100% of people die at some point at the end of their life, and it's a taboo subject, like I said at the start, and that involves disabled people as well. We all are equal when it comes to the forces of life and death. And so what disabled activists for Dignity in Dying is attempting to do over the coming months and years is really try to get the disabled community to talk about death in the positive aspects as well. End of life care, ensuring that disabled people, we get terminal illnesses as well as having a disability on occasion. Cancer and diseases like that can befall any of us, and so we have a right as well to talk about how end of life care should look for us. And yes, I think ultimately, only recently the deputy chair of the BMA, he said that he thinks after committee stage an assisted dying bill, a law, will become legal within 2 years. And he said that in the Observer just a few weeks ago. I think that's probably a little bit optimistic, but do I think assisted dying will be legal and protect disabled people in doing so by 2020? I think that's a good likelihood. Thank you.
Thank you very much. And now we'll move straight on to Michelle.
I've been specifically asked to talk about these issues, to consider the nurse and what nurses and doctors face in the midst of this debate. And I think it was once said that what's one of the biggest wonders of our human condition, or what's the biggest thing that we wonder about? And somebody once said, the biggest wonder of our human condition is death is all around us, visible, clear and obvious, yet nobody thinks it's actually going to happen to us. And we live with that contradiction constantly, and I think that's at the heart of this debate. But obviously, I can't speak for all doctors. I'm a nurse by background. I'm speaking here, and what I'm going to do is offer you a summary of what the research is from patients and professionals through the lens of 25 years as a registered nurse, working in trauma orthopaedics, helicopter emergency medical service in London, working in community practice, working with a range of people, but also 15 years worth of pain research, working with my palliative care colleagues around how to help people live with pain, and 5 years as a university chaplain. So that's the area that's the lens from which I'm giving you this work. I want to focus on three things that I've said there. And the first one is the clarity of terms. When we talk about assisted dying, what do we actually mean? And it's very clear that we all think we know what we mean, and we all have a particular definition. And certainly about your discussion about the assisted dying and assisted suicide being two very different things, as is euthanasia. And from a medical point of view, certainly the Oxford English Dictionary says assisted dying is the suicide of a person afflicted by an incurable disease using a lethal dose of drugs provided by a physician for this purpose. That's what the English Dictionary says it is. That's not what I think Dignity in Dying say it is. Dignity in Dying, the definition is assisted dying allows the terminally ill person to have choice. This is what Sharon was talking about, over the manner and timing of their imminent death. So two very different things, and yet they're both assisted dying. From a clinician's point of view, the clinical reality is assisted dying is a complex array of shared decisions about living and dying, because actually we don't flick a switch in our lives. One day we're not living and the next day we're dying. We are both living and dying every day. And some people are closer to it than others, but the reality is both of those things are happening. And when you're helping people with the end of their life, there are many things that shared decisions about living and dying are compacted into assisted dying. First, to choose or refuse life-sustaining treatment when it becomes burdensome or futile. Linda Bellingham is the latest example of that, deciding to no longer have chemotherapy. To choose or refuse indeed any treatment option for any reason. To choose supportive care when you want it, where you want it, where you would like to die, how you would like to die, and how you would like to be able to have your symptoms controlled. To choose to end your own life. To ask somebody else to help you end your life. To ask a doctor to provide you with the means to end your life or hasten your death. The first four are legal, and the debate circles round the last two. And from certainly my perspective, the debate is not about a right to die in terms of the legislative framework, but whether we as a society should give one person the freedom to end another person's life legally. And that's from a doctor's perspective. We're specifically talking about, should a doctor or nurse be allowed to end somebody's life? And as you've heard, doctors and nurses don't agree with whether there's a right or wrong answer to that. And there are proponents for. This is from the Journal of the Royal College of Physicians this year, with Graham Catto and Sir Graham Catto and Baroness Finlay. Sir Graham Catto's view is, as a compassionate society, we should be ashamed and angry that we still deny the dying a dignified death so many seek. For too many grieving friends and relatives, the lasting legacy is not a life well lived, but of a grim, institutionalised death in uncaring surroundings. Although we wish to die peacefully at home, most of us will die in hospital. Why not ask patients for their views and provide a real choice at the end of life care? That's one medical position. Baroness Finlay, on the other hand, says the real world of clinical practice is very different from the idealised world of these bills. They depict a doctor who has notably strong health views themselves, so that they don't have an opinion over physician-assisted dying or assisted suicide, and they will be able to examine any request dispassionately, without prejudice, without time pressures of workload. A doctor who can confidently and accurately predict the course of a progressive illness, that his or her patients, they're able to know his or her patient's personal and family circumstances well enough to be able to say with assurance that there's no pressure, subtle or otherwise, working in the background, and that the doctor also will be able to assess the level of capacity that is required to make a decision, so that to assess that people are mentally competent and that there's no depression and there's no other reason why somebody may want to take their life. And in addition to that, they have to be independent from the case. And when doctors talk about this, the one point that I will make is it's a matter of fact that we know that predicting whether you are in the terminal phase of your illness is almost impossible to do. Doctors get it wrong all the time. And there's studies, one recent study showed that the accuracy levels were as low as 20%. Doctors cannot be certain that you're in the terminal phase of your condition. So actually, doctors cannot be certain about an awful lot when it comes to a progressive illness. They can't be, as Sharon mentioned, they can't be certain how you are going to respond to your symptoms. They can't predict how long you will have your symptoms. Indeed, they can't even predict how many symptoms you might have. They can have an educated guess, but they certainly can't predict with accuracy. And that's one of the challenges. But Sir Graham Catto says, really, and you're absolutely right, that the patient stories are very important, and they're very important to this debate. And I was very pleased to read a systematic review. This is why are people asking about the right to die? Why do we want it? And this is a systematic review. And systematic reviews pull together all of the available research in a particular area. They're a way of pulling together all of the studies, and this is a qualitative systematic review, so this is any survey, but also qualitative studies. And they were particularly interested, and the authors wanted to look at anybody the patient's views and opinions and perceptions and attitudes of anybody who's experienced assisted dying for adults, so that have been involved in either have been part of a decision for assisted dying, have a terminal or long-term condition and they may have considered assisted dying. And there are 110 studies in this systematic review, 16 of which are qualitative studies gathering stories about why people were asking for the right to die, and 94 surveys. And they came up with 4 key themes, which we've touched a bit in this debate, but there's 4 key reasons why somebody would want the right to die. The first is a poor quality of life, and what I'd like to do is just take these 4 and talk a little bit about them. Poor quality of life, as a large term, is a very difficult term to grasp, but the groups of people in the systematic review described that a poor quality of life was feeling a burden on others, being dependent on others, being lonely, and extremely or poorly controlled pain, or indeed fear of it, because the difficulty is that it's a fear of poor quality of life. It's not a decision of where we are now. On a number of occasions, it was the fear of poor quality of life. But actually, in terms of the pain, this is a direct quote from one of the interviews. Pain also featured in the accounts of two patients, one of whom asked to be killed and one who attempted to kill himself. Neither acted to procure their death once their pain was under control. And this is a key reason why the Royal College of General Practitioners remain opposed to a change in the law, is that it has the potential to shift the focus from providing good quality of palliative care. And there is a real risk, and certainly the Royal College of Physicians also say this, palliative care, in the consultation exercises for the Royal College of Physicians, they say palliative care was widely seen as patchy and in need of investment. And I think it says something about our society, that the vast majority of palliative care is delivered within hospices and is funded for by charitable donations. Most of our palliative care is not funded within the NHS budgets, but we talk about NHS budgets within palliative care. But certainly a large proportion of hospices are charitably funded. So certainly fear of poor quality of life. The desire for a good quality death, and that's defined as a right to choose, to retain control, the things that Sharon was talking about, but also to avoid pain. The most frequently cited reasons for wanting to have a patient-assisted suicide, a patient-assisted death, was a freedom to avoid suffering and avoid, again, reducing burden of family and loved ones. And again, this is another reason why most of the professions are opposed to a change in the law. For example, there's a recent survey, I don't know if you've seen, that just published recently, a survey of 7,721 responses in the Royal College of Nursing, say that many healthcare workers are profoundly troubled by an inability to always care for end-of-life patients in the environment that they would wish. The resources they talk about the resources. Almost half of responses suggested nurses do not always have the chance to speak with patients about their preferences at the final days. If you add that to the issues around being able to deliver compassionate care, the issues about being able to care for patients at the end of life, being known is a key factor. Being known when being sure that people are making the right decision about assisted dying is a key factor. And certainly the need for safeguards is a huge concern. The concern and these are patients' concerns, these aren't professional concerns. There's a concern that they're not concerned of physicians abusing. They trust their doctors to do the right thing of them, but they are aware that, and I like this, that doctors are not skilled enough to communicate about death and dying in their experiences, and doctors agree. The other particular event is the real importance of individual experience. The key fact here is if you have a good experience within your family network of death and dying, you're less likely to want to have an assisted dying legalised. If you have poor experiences, you're much more likely. Very often, this is another systematic review, and very often people say that, oh, well, what the doctors and what the public want are at odds. And what I thought I would do in my last couple of minutes is say that these are the themes from doctors. So if we think about the patients said, fear of poor quality of life, wanting good palliative care, the need for safeguards, what doctors are actually saying is they're not entirely sure, exactly coming back to Sharon's point about being the duty bearer. They're not sure doctors are the right professional group to be the people who make the decision. But they're also not sure that what we're doing is fundamentally undermining the social process of grieving. And the summary that I would leave you with is patients ask for the right to die because they fear poor quality of life. What we should be doing is increasing an emphasis on palliative care resources to meet everybody's needs. And that's not to say that sometimes that isn't able to do, but we should be, there's a real fear within the professional groups that if we legalise assisted dying, we're less likely to get all of the resources that we need for palliative care. Choice, autonomy and control. There's uncertainty about the role of the doctor and nurse. Doctors say, absolutely, we want to support patients' rights, but we recognise there's a power imbalance here. We recognise that a lot of patients would say, well, what would you do if it was your family doctor? What would you do? And we recognise that actually the amount of information that we have that we're certain of within nursing and medicine is not... our accuracy of diagnosis isn't, when you're wanting us to make decisions about this, we could get it wrong. What we need to do is models of shared decision making and make sure that we've got those models of shared decision making. When we talk about safeguards, what the general feeling is that actually in order to legalise assisted dying, the safeguards need to be upfront before you make the decision about the law. What we don't want is to effectively make it law and then try and work out the safeguards. That's a real challenge there. And the final thing is the individual experience of death and dying within your family. We've all had experiences. We all know just how much those experiences have an emotional toil. Equally, that's the same as the individual experiences of nurses and doctors. And when nurses and doctors are talking about their individual experience, my experience probably, I was hundreds of patients that I've had the privilege of journeying with them to the point of death. And lots of people have lots of voices to add to that. But if it does so, my final thing would be to say, if assisted dying becomes legal, we need to spare a thought for the nurses who are asked to do that and the emotional labour of doing that, and the governance of being able to do that, how we provide training, how we provide audits, how we make sure that that's safe. And I think that's
Great, thank you very much. Right, thanks to all three speakers. I'm sure you all agree, three excellent contributions, and I think they really kind of fitted well together, blending kind of academic campaigning and practitioner kind of perspectives on this issue. And I'm sure that everybody will share my view that whatever your thoughts on this were when you entered into the room, whether you sort of felt you supported assisted dying or not, you've certainly been given a lot of, a kind of pause for thought, a lot of issues there to think about. So we've got about 25 minutes for questions or comments. I'm just going to open it up to the floor. What I'm going to do is probably take about 3 questions and then let the panel respond. And then just see how we go with that, really. So if you could just try and keep the questions fairly brief so we can get through as many as possible, that'd be great. So one here, and then just another one there. A third one. Third one here. Oh, sorry, I'm looking over there. Oh, you're all the ones that are trying to go for you there. Okay, I'll come back. Okay. So start here.
If the UK was to legalise assisted dying, who would cover the cost? Would it be the individual or the state?
Okay, good. And then
here. Yeah, my question is mainly directed to Shannon, because on your presentation it was stated how one of the quotes was a family member. How would you resolve the issue of if the family wanted, because if the individual was in a state where they couldn't speak or they couldn't make a decision themselves, you have the issue of inheritance where the person or the family member would actually, because it does happen, I know from fact that people in society do, if they want them to die, to claim an inheritance, how would you go about resolving that? And the second point related to that question is, should we not have a legal form document like a will, where the person, if they stated before, if they knew they were terminally ill, and it was stated before they were actually getting to the worst part of that disease, where they could actually state in a legal document, if they got to this state, whether they wanted to be treated like this.
Okay, great, thank you. And then
so with people suffering with mental health disorders, such as chronic sort of depression, which can prevent speech and things like that, would that mean that they were exempt from assisted dying under the new proposed bill, in which you have to be of sound mind? If so, how is that sort of justified? and also for those others who can't talk for themselves, who would have the right to decide for them in case they've sort of assisted suicide.
Okay, great, thank you very much. So, I don't know how you want to, you don't all have to answer all the questions, but obviously as long as somebody answers all of the questions.
Okay. Yes, first of all, with cost. In terms of Lord Falkner's assisted dying bill, it's been drawn up, says on the face of the bill, as a piece of public healthcare policy. So it would be the NHS that would pay for that. But importantly to note that, as well as the choice of assisted dying, that would be maintained strongly as an umbrella of options, including palliative care. So we're not pushing for that choice and nothing else. So the cost would be put across all options still. In terms of family and coercion, the individual has to make the choice themselves. It can't be anyone else. And importantly, under Lord Falkner's bill, they have to self-administer the life-ending medication. It can't be anyone else, including the medical staff. It has to be the patient that does that. I think one point you made about having prospective decision making. There is an important document which used to just be called termed a living will, which is actually called an advance directive now. I would, even though we're all young, I would urge you all to find out about that. Because it's a really important document where you can set out your personal choices at your end of life, however, whatever situation you may find yourself in. But under Lord Falkner's bill, the advance directive wouldn't be applicable in terms of choosing an assisted death. And that moves quickly and nicely on to mental health and depression. So if you had dementia or Alzheimer's and you had an advance directive, that wouldn't apply. You wouldn't be able to choose an assisted death prospectively. And in terms of depression, I suppose under the Mental Capacity Act, there's a clear definition of what being mentally competent and a being sound mind is, and you can meet that and still have depression. I think one thing to make clear is there's many different forms of depression. You can be depressed and not be terminally ill, and then you can be depressed because you are terminally ill and you are dying. I'm sure there are people, and I think we've all seen them in the press from time to time. But I think for most people, if you're dying from cancer or Huntington's disease, like Heather Patton's son, it's going to be pretty hard not to be depressed. So you can still have that state of mind, but still come to a sound and reasoned decision and take control of that disease.
Okay, thanks, Greg.
I would add to that the comment in terms of making advanced, your living will or the plans is one of the real challenges with doing that is it requires you to imagine how you'll feel when you have that condition. And the only time I've ever been in a place where I've had to plan medical decisions is when I went through the birth of my children, and I had to do a plan for how I was going to manage. I'd like this, but I wouldn't like that, and frankly, when I got there, I want everything. And my plan and what I decided I would like and what I was willing to have and not have were very different when I lived the experience, and that's my experience of caring for people with chronic long-term conditions. What you think you might want to have and what you think might be intolerable or tolerable changes and is dynamic, and it's very difficult to be certain. Some people stay certain. Some people move their opinions when they actually are experiencing it, and that's a real challenge with having something that's beforehand that then is applied when that thing happens.
Okay, thank you. Sharon,
just to add as well, the thing about advanced decisions is that you can spend a lot of time writing down your wishes and your requirements. But unless you tell everybody else, or unless you have a visible bracelet that says, I have an advanced decision, if you're out shopping and you collapse in the car park, you know, people will call an ambulance and you will be treated and resuscitated because that's their job as medical professionals. So people have to be aware that you've got an advanced decision really for it to work, and even then it has to be considered carefully.
Okay, thanks. So Rob, and then Robin, and Rosie.
I've got quite a coming from the left question as usual. Companies such as GSK and all this make a lot of money in drugs that treat terminal illnesses and disabled people. Are you worried that the influence they have over government policy could influence the bill going through? I mean, exploiting disabled people with terminal illness, getting profit out of this money for them. So are you worried that their influence over lords and MPs could badly influence the bill going through?
Okay, good question. Robin.
My question stems from Michelle's point, but I'd be interested in Michelle and Greg's view on this as well, because you were saying that doctors feel that potentially they're not the person to make this decision. So my question is, who's being suggested to be the person to make this decision?
Okay, good, thank you.
Yeah, just around the point about how you talked about the kind of emotional effect it would have on doctors and nurses. My question is, how is helping someone to die with dignity and doing something so compassionate worse than watching someone suffer and watching someone die in like a much worse way? How is that more emotionally traumatic for doctors and nurses who surely would be used to death as a thing?
Okay, so good about the emotional burden, kind of either way. All right, thanks very much.
Yeah, I can say. I think it's not an either or. One palliative, when I was reading some of the transcripts of this is from the responses to the professions for their surveys. One palliative care nurse said, I find it, as a midwife assists birth, I assist death, and it's not a case of hastening someone's death or watching them suffer. Actually, I'm actively advocating making sure that I'm intimately involved in making sure that this person does not die in uncontrollable suffering. And the vast majority of people who die don't die in uncontrollable suffering, have a good death. There is a minority of people for whom we are not able to fulfill that, but the desire is, it's very rare that somebody watches somebody, but also what they're saying is the emotional burden of, there's a difference between doing everything you can to help people live well to the end and actively ending somebody's life and being part of that decision. To I am the agent of your death is a different thing to I am here actively helping you on the process of dying. Does that?
But isn't the issue about where palliative care doesn't work? So in the case of Tony Nicholson, he wanted to die because presumably palliative care wouldn't offer any quality of life to him. So in that case, he was watched, dying instead of being allowed to die. And that's your
Although actually this
question.
confounds it, because actually people with chronic neurological conditions or long-term health conditions don't get access to palliative care, because palliative care, in order to get access to palliative care, you have to be assessed as having a terminal illness, and Lord Falconer's bill is about assessing a terminal illness. So our ability to provide palliative care to the living is a real challenge, and that we would like to do. I think a lot of doctors and nurses would like to do more, and what they're saying is that in this present climate, actually, certainly as a pain researcher and a pain specialist, we constantly say that we need to be able to do more with people who are living with chronic long conditions to be able to support them to live well. And we recognise that that's not something that we do, that we don't always do well. So.
Good. Okay. Sharon or
I
Greg?
think I'd just like to respond to you about, I think a lot of people that work in palliative care, and particularly Baroness Finlay, who's chair of the British Medical Association, they tend to see palliative care as being able to respond to all types of suffering at the end of life. And that just isn't realistic because, yes, palliative care has advanced incredibly in the fields of pain control and wound dressing and many aspects. But when you're dying, there's also the emotional anguish and the spiritual struggle with managing your dying that I don't think palliative care can address adequately, perhaps due to research, perhaps due to funding, perhaps due to resources available. So I think there's a gap there. Coming back to Robin's question about if the doctors aren't going to be the duty bearers, who is? Well, following the assisted dying debate in July, there was talk about the law courts, as you said, the family division of the law courts. If you wanted to request assistance to die, you could come before a court of law, and they are used to dealing with emotional and difficult issues. But actually, Greg and I went to a meeting last month with healthcare professionals who are in favour of assisted dying, and I thought the ethos was that the doctors present didn't really think the law courts were suitably qualified to make these decisions.
Yeah, they weren't in favour of it really, were they?
No.
No.
So then there is the issue, if not the doctors, if not the law courts, then who?
Yes, in terms of your the issue of GSK and the pharma industry, I have to say, I know you've been following the possession of the bill through the Lords as well. I haven't really seen any big representation from the pharma industry to date. I think I actually had a very similar conversation at that same healthcare professional event last few weeks ago, and they were talking about the drugs that you would use and they would use as healthcare professionals, and the impression I got from that was that all the apparatus and things they would need to affect a legal right to die well, that's already out there. So I can't really see pharmaceuticals making some sort of big win by having it passed into law. But ultimately, with government policy, they have to hear all sides and all submissions of evidence. But I think what you find is when you speak to parliamentarians about an issue like this, essentially which is one of life and death, they are very careful. That's why earlier provisions of this issue when it's come into bill proposals over the years, back from when was it 1936? Yes, all the way. That's why it hasn't passed so far, because people are really wanting to scrutinise this and make sure absolutely no mistakes are made. I think also looking at decision makers. Was it yourself who asked? Yes. I think in terms of I suppose there's two types of decisions, isn't there? There's the decision that you want to die because you're terminally ill, made by the patient, and that's first and foremost at the very heart of the bill. And then you've got the prognosis decision as well, made by the healthcare professionals. Now, one thing I wanted to just to pick up from one of the earlier presentations was that prognosis is it's not a simple thing. It's complex and it's individual. So there's one of the disabled opponents, or they regularly used, is even though Stephen Hawking, the physics professor, supports assisted dying for terminally ill people, our opponents regularly use him as evidence that prognosis evaluation doesn't work, because he was told when he was born that he would die, I think 2 or 3 years, I think, and obviously look how old he is now. But the difference is there's a determination when the prognosis is made. When it's made at the very start of life, and you're trying to double guess life expectancy with very little individual data, and when you are an oncologist or terminal illness expert, and you've been following this patient, you've got a lot of data, compare it to previous data sets and personal experience. I think when you look at that, and also the fact that the prognosis rates and the accuracy rates can be very different different types of diseases and different subsets. It's really, that's why it's important you have two independent doctors to assess not just the individual, but the individual disease, and make sure the accuracy rate is as high as it possibly can be. And I think, I know we're being collegiate, and we've now accepted the opposition's request to have a judicial mechanism. I think that's important. I know Sharon was talking about, should it be one or the other? I think both is a really good step forward, because not only will two doctors have to, come to independent decisions and present it to themselves, I can probably see them having to give evidence then at the court and explain their prognosis, and the judge will say, what. And I think what would be best is if they give evidence separately without each other in court, they'll say, well, why did you come to that conclusion? And if they start disagreeing with each other in separate statements, that will highlight that. So that's an important safeguard. I think with healthcare professionals, ultimately in the bill, there's a key point that if you don't agree with assisted dying and assisting someone so they can self-administer any life-ending medication, you don't have to take part in it. And I know we talk about polling, but both sides do. But in one poll that has been commissioned by the same group at the event we were at the other week, Healthcare Professionals for Assisted Dying, we have found that about 33% of doctors would be happy to participate in the process, which is enough for national coverage if it was to go into law. Although when you speak to, especially a lot of the younger doctors, they are in the opinion that it's not their decision to make. It's for those with legal responsibility, the decision makers. And then if it is put into law, then as long as it's explained to them and there's proper medical ethics built into the process, then they'll make a decision then whether they want to be part of it. And I think that's a key point with healthcare professionals. You don't have to participate, but there is a group who do want to.
Okay, thank you. Michelle, you want to...
I just wanted to pick up on that. You don't have to participate, and just logistically how that would work, because certainly in my experience of nursing, how you avoid being part of that decision, I can't see a way. If you conscientiously rejected, I can't see a way on many wards how you could avoid being connected with that decision, or indeed how you're going to have to refer, so because nearly every person that I can think of would want to have that conversation with somebody who knows them. So it's that link between, we need two independent doctors, but it's unlikely that the patient is going to go to an independent doctor to request this. They're going to go to the doctor that they trust and who knows them well. And then that doctor or nurse has to decide how they refer them on. So you're then already participating.
Well, yeah. Say you were the you were the treatment professional giving the current treatment, and the request was made to you. You'd have the fundamental responsibility to pass on the request, but then past that, you'd have the option to have no part of the process beyond that.
But actually, in order to be making the decisions, they're going to talk to the doctor who knows that person well. But they're going to need to talk to that doctor, because they can't make independent decisions without getting a full case history from the person who's looking after that.
I think the patient would have to accept that, this is a very special aspect of healthcare, and that if the doctor doesn't want to participate, they don't have to. So you'll have to accept the practicalities of to deal with a new doctor if that came up.
Right. Yeah. Okay, sorry, I just want to see if there's another set of questions, because we've just got time. So I was hoping that somebody put their hand up, otherwise it would embarrass me having stopped that discussion going on there. So I think we've got three more. One here, Ioana and Jimmy. Well, let's go, if we can fit four. You wanted to ask as well? Yeah. Okay, so we'll go for those four. I think that'll probably be, you just try and make them fairly brief, and then we'll have to wrap up then. Okay, so in that order, if you want to start with.
If the UK doesn't move to legalise assisted dying, do you think Parliament should make it easier for people to go abroad, like Switzerland, like you mentioned, to be able to do so?
Okay, good, thank you. And who was the second? Was I forget the order. Joanna?
Yeah, it's more like a general comment. I agree with the fact that doctors or nurses shouldn't do that decision because it has a huge emotional impact on where I'm coming from. My father is a doctor, so I can relate to that. So basically, the doctor's role is to save lives, and the medicine is there to cure. It's like I think we need a different type of profession for assisted dying, but not doctors, because what doctor mean is to save lives. Secondly, it's like we should have the right to choose our own death, but does anybody in this room choose to be living here or to be born in UK or in Europe or in Africa or wherever? No. So maybe we don't have this kind of right over that.
Okay, right, thank you very much. So do me and then come back to you.
I was just interested in your research. You said, I think there's something that you all kind of highlighted, that actually this issue tends to be certainly interested in mostly, gets a response from the middle class per se, and telling that also, your research, the group that you go and speak to are in Hampstead, which is obviously a very, elite area. So I just wondered, is there an attempt in general to actually extend this discussion so that, other folks are more involved, so that it's more representative of society in that sense?
Okay, so questioning the methodology, research, and then finally.
Do you feel that the UK government's /UK legislative position on assisted dying stems from religious opposition, i.e. Christian churches' stance on assisted dying?
Good, so religion, that's the unmentioned thing so far, really. Okay, so I have to ask you all to be fairly brief, but if you'd like to come back.
Representing a religious institution. I think it's very difficult to know. Certainly, being of a faith background, when you look at the research evidence, the latest research that I've read was that having a religious faith is positive to assisted dying, so that you're more likely to support assisted dying. I've read other research that says actually religion you're much more likely to oppose, so that there's evidence on both sides. And I think it comes back to Greg's point about actually being religious is like being disabled. We've got, actually I need to reframe that. Don't quite mean that, but that actually the religious community and the disability community have a range of views across the board, and it isn't one view or another from a faith point of view, that we have a range of views in the same way that some disability organisations are fervently opposed, other disability organisations are pro. It's probably the same from a religious point of view.
Richard Dawkins might say that people with religious views is like being disabled, but
I just want to retract that. I'm not saying that at all. I'm saying that it's a community like any other community.
Yeah, sure. Okay.
Just responding to your point, yes, I absolutely agree. It does seem to be white, middle-class, educated people who have a habit of being in control of their lives that support assisted dying. So it would be good to perhaps come even further north and look at working class people, how their attitudes are to assisted dying. When I originally wanted to look at public voices, I wanted to interview terminally ill patients at my local hospice, because I thought the bill's about legalising assisted dying for people who are dying. If you're making a law, you need to talk to the people who are going to be affected by the law. So I went through a very long ethical procedure and sat before the board in London, and they turned down my proposal. They didn't think it was ethical for me to ask people about assisted dying and end of life if they were dying themselves. Yeah, I'm going to go back soon, don't worry. But then I applied to the Motor Neurone Disease Association, and I did get approval to interview people who had motor neurone disease, but there was such a small group in my local area that the 3 interviews I did with them probably wasn't enough to do a good study. But yeah, I would like to carry on, because I think having group discussion about what people really think about end of life is really important. And I don't think you can have a credible bill without really getting to the bottom of what the public think. I think polls and surveys are all great, but they are ideological instruments. Basically, you can get anybody to answer depending on how you ask the question. Yeah.
Okay, thank you.
I think on your point about, if it wasn't to be passed, what would we do then? I think if you're prepared to, if you're not prepared to legalise assisted dying in the UK, then I can't imagine decision makers being prepared to spend public money on making it easier to travel. I think, and ultimately, like I was saying in my speech earlier, you've also got the notion that it's not just a monetary barrier. You've also got the barrier of health as well. So I suppose if you really wanted to, spend, you could enable a terminally ill person to travel to Zurich if they can't currently. But I suppose one of the key points of why we're campaigning for an assisted death and for terminally ill people to have that right is it's that quality of experience of having a good death. And being medevaced to Zurich probably wouldn't be the sort of experience they're looking for. And in terms of doctors and whether you can qualify that as to participate as a doctor or not. I know I spoke at Nottingham University a few weeks ago, and I had a medical student asked me a very similar question. And in terms of the Hippocratic Oath, one of the key tenets of that is patient welfare. And I suppose ultimately opens it up to personal interpretation. But as polling has shown, and personal testimony from a range of medical professionals, there is a significant group of people who they make the interpretation from that and from other medical documents and codes of standards that they can participate. So there is a group who are willing to do that.
I think it's fair to say that the GMC, the BMA, the Royal College of GPs, the RCN is neutral but doesn't lobby either for or against, but all those other professional bodies oppose a change in the law.
Yeah, the leaderships do predominantly, although it was interesting, I think it was the Royal College for General Practitioners. They recently surveyed their members, which I think number tens of thousands in total, but the actual response rate was only a couple of hundred, if that, but they didn't mention that when they put the results out. So I think there's more research to be done, but no, you're right, the leaderships definitely, by and large, disagree.
And the survey methodology, I think that's a very good question, is how we survey and how we elicit opinion.
Okay, clearly we could go on for much longer discussing this issue, but unfortunately I have to call it to an end. So thanks very much everybody for coming. Thank you.